Hello, Level 3 students. This is Dr. Mary Mancow. I'm here to talk to you today regarding healthcare advice for international travel. This lecture is one of your correlate lectures for the infectious disease module. But more importantly, we want our travelers to be safe, healthy, and happy. So in the next hour or so, I hopefully will give you some advice that you will use as physicians to give the travelers so that they will be safe during their trip and actually enjoy their trip. The references for the lecture today will be found from two sites. So the first one is Harrison's Principles of Internal Medicine, the 20th edition, chapter 119. So it will include all the precautions that you need to give the traveler, including also vaccines, their indications and contraindications, and then also a brief review of certain disease conditions. The second reference is the CDC, so the Centers for Disease Control and Prevention. There is a travel website where they regularly update their health notices of certain outbreaks or any important diseases that are happening in a specific country. So this website will help our travelers at least with some warnings or any preparations such as vaccines they need before they travel. So the objectives for this lecture include one, travelers' health epidemiology. So it is important to remember what are the precautions a traveler needs to undertake prior to travel. This will also include specific vaccines and diseases in specific countries. Two, it is important to do a complete traveler's assessment. So this will include all his pre-morbid conditions. So we are looking at history of diabetes, a history of hypertension, or any past surgical conditions that may limit the patient's or the traveler's experience. Number three, it is important to do an itinerary review. So what are the countries this traveler or patient will visit? It is also included. It is also important to include stopovers along with their final destination and how long the patient will be traveling to that specific country or place. Four, it is important to look at the risks to travelers so they are at least prepared prior to travel. So we're looking at enteric precautions, bloodborne precautions, and environmental precautions and risks for this traveler. So then we will look at travel vaccines, their indications and their contraindications, because there are certain required and recommended vaccines for a certain destination. And lastly, we will talk about the countries and specific countries and what diseases that can be unique to this country. So as I mentioned in the beginning, it's very important as a physician that we do give pre-travel advice to our travelers. We want them to be safe and happy. And we want to create good memories for them when they travel. So as a physician, right, there are two things that we need to do when the patient comes to see us in the office. So first, you take a good history, including past hospitalizations, operations, any diseases that have happened prior to this travel for the patient. Then also really take a good review of systems. Make sure and go through all the systems from GI, neurologic, cardiovascular, respiratory, so you can truly assess the condition of the patient. Then, second, make sure you do a thorough physical examination. Look for any stigmata of, like, for example, congestive heart failure or respiratory distress that may limit the travel experience for the patient. It is important to start with the two basic tenets of medicine. So it's good taking a good history and doing a thorough physical examination. So for travelers, it is important to avoid injury and avoid death. So therefore, we need to go over certain health risks that the patient will need to watch out for when they're traveling. So when you are assessing injuries or death in international travel, a study published in the Annals of Emergency Medicine looked at what are these occurrences. So the number one cause of injury or death was motor vehicular accidents. Second was drowning, and this also as a caution to travelers who travel with children that especially if children are unsupervised around water, it is finding that they have seen near drownings or drowning incidents of children who are unsupervised, especially around water. So our travelers have to be very careful when traveling with children. Next, cause of injury or death are air crashes, which is self-explanatory. The next are homicides and suicides. So many homicides, especially if you're in an area where there is very lax or poor peace and order situation. The next is poisoning as a cause of injury or death. This mainly is due to if you're unfamiliar with the local, food or toxins that you need to avoid. So when you give travel advice, remember it is important to remember the patient. As I said, a very good assessment starting with a good history and physical is important. But next will be really to take in consideration all the medical issues, past or present, for your patient. When you're assessing a traveler or a patient who will be traveling soon, so make sure that the patient has received routine immunizations, which we will talk about later, and travel-related vaccines. So as I mentioned, it is important to go to sites like the CDC travel website because there are countries and the vaccines listed for the countries that are required for entry into the country. It is always good to remember when we say immunizations, when you're talking to your patient who wants to travel. So remember there are two kinds, right? The childhood immunizations and then the adult immunization. And let's go over these. For routine immunizations, we are talking about diphtheria, tetanus, and polio, measles, mumps, and rubella, influenza vaccine, and the pneumococcal vaccine against strep pneumoniae. It is important to remember, though, that as a child, you get those doses, but it is important, though, to get booster doses. Therefore, as an adult, you receive booster doses such as DTaP, so diphtheria, tetanus, and acellular pertussis. And then every 10 years, right, you get a booster dose of Tdap. For the measles, mumps, rubella, and varicella vaccine, usually a second dose is required. For influenza, you get that yearly, and for a pneumococcal vaccine, it's usually after age 50, or you have an underlying condition like asplenia, complement deficiency, or sickle cell disease. There are certain conditions we need to think about for our travelers regarding our routine immunizations. So let's start with diphtheria, tetanus, and polio. It has been studied that tetanus antibodies are diminished or are lacking, especially for travelers who are greater than 50 years of age. As for polio, wild-type polio has been eradicated in the Western Hemisphere. However, there have been several outbreaks of polio, so it's important, as I said, to look at that CDC travel website for outbreaks. And then it is important that your patient, adult patient, receive a Tdap, so that's tetanus, a smaller dose of diphtheria, and acellular pertussis. It is recommended that the traveler will get a booster dose every 10 years because the immunity wanes. Okay. Next disease is measles. So it is important that those born after 1956 and vaccinated before 1980, they are at high risk for disease because at that time when they got the vaccine, apparently the immunity has waned. So in fact, they need a booster dose. So actually, they actually also will receive a booster dose, not just of measles, mumps, and rubella, but sometimes also for varicella. So you use the MMRV vaccine. For influenza, it is important to remember that it occurs all year round in the tropics, so especially like countries in the Philippines. And then in the summer months, it occurs like in places in the southern hemisphere, such as Australia. And therefore annual vaccination is recommended.
Back,
So for the
Hopefully you
pneumococcal
had a nice
vaccine, remember
break.
it is
I know it was
routinely
probably an early lunch for
administered
you,
in
so I
ages greater
appreciate
than
you
65 years of
having your break
age,
early so
and
that we could
especially
have our
those who are
session
high
now so that
risk of
it's not
infection,
too late for me in my time
those
zone.
with chronic
Thanks for
conditions,
cooperating with
chronic
that. I
heart
appreciate it.
conditions, lung and kidney
I'm going to start
conditions,
recording
and
this
especially
session.
those with sickle
Just so
cell
you know, I'm going to
disease.
hit the record button.
For the required vaccinations, it is important to remember at least 3 of these. The yellow fever vaccine, the quadrivalent conjugate meningococcal vaccine, and influenza vaccine. So as required immunizations, right? So these are required in countries to enter. Therefore, you will not be given a visa to enter a country unless you show or proof that you received the vaccine. Required vaccinations include the following. So first, the yellow fever vaccine is required and recommended, especially in travel to sub-Saharan Africa. And so these are countries below the meningococcal belt. So and also countries located in equatorial South America, and which we will discuss further when we talk about the specific vaccines. Next is the quadrivalent conjugate vaccine. Why quadrivalent? Because it is targeted for meningococcal serogroups A, C, Y, and W-135. And this vaccine is required for entry into the Hajj, which is a ritual for the Muslim faith. And then third, the third required vaccine is influenza. Since especially both seasonal and pandemic H1N1 vaccines are also required for travel to Saudi Arabia, but in most countries where you travel to, this can be required vaccination, especially now with the COVID pandemic. Recommended vaccinations are immunizations that are considered to be routine for certain countries, and therefore also recommended before entry into the country. And as I mentioned previously, it is important to always consult the CDC website because for a specific country, there are travel health notices regarding outbreaks in an area. For example, an outbreak as of now for COVID-19, but also certain other outbreaks like for either polio, cholera, or typhoid fever, where you can use a vaccine or it may be a vaccine that is required prior to travel for that country. So we have gone through a background of traveler's assessment, traveler's epidemiology. So And then we have talked about required and recommended vaccines. So now let us talk to specific travel vaccines that are required or necessary before entry to a certain country. So let's start with the hepatitis A and B vaccine. So hepatitis A vaccine is recommended for people who are unimmunized or underimmunized and are traveling to areas with intermediate or high rates of hepatitis A infection. These include all areas of the world except Australia, Canada, Japan, New Zealand, and Western Europe. So remember that inactivated hepatitis A is used for post-exposure immunoprophylaxis for people who are at least 12 months and to 40 years of age. So, and also that there is an immune globulin, that can be used for post-exposure prophylaxis in children less than 12 months of age, immunocompromised host, uh, patients with chronic liver disease, and patients for whom the prophylaxis of hepatitis A infection may interfere with an immune response to, let's say, varicella and MMR vaccines. So it's also to remember, good to remember though, there's a combination Hep A and Hep B vaccine that's available for people and patients greater than 18 years of age. So for hepatitis B vaccine, it's recommended routinely for all children and adults who are considered susceptible travelers, and also who are visiting areas where hepatitis B infection is endemic. So we are talking about countries such as Asia, Africa, and some parts of South America. There can be an accelerated dosing, so it's important for some patients who may have emergent travel. So there can be an accelerated dosing schedule for hepatitis B vaccine. However, usually it's given usually of a space of 6 months, but the accelerated vaccine schedule for hepatitis B is given at 0, 1, and 2 months. And as I mentioned previously, there is also a combination Hep A and Hep B vaccine that can be given for patients 18 years and older. And this combination vaccine is a 3-dose schedule, so 0, 1, and 6 months. For the polio vaccine, polio remains endemic, especially wild-type polio, in a few countries in Asia and Africa. And as I mentioned earlier, remember, always check the CDC travel website. The Western Hemisphere was declared free of wild-type polio virus in 1994, and then recently the Western Pacific region was declared free of wild-type polio virus infection in 2000. But recently there have been outbreaks of polio, so always good to check that CDC website, travel website regarding outbreaks. Um, so it is important then that our patients get really the 4 doses of IPV, which should be administered at 2, 4, 6 months, and then again a booster at 4 to 6 years of age. But for the adults, the travelers who are 18 years and older who are visiting these regions where there are outbreaks of polio, these patients should receive a booster dose of IPV. And certain countries such as Pakistan, Afghanistan actually require this for long-term visitors. So those who stay greater than 4 weeks, they have to show evidence that they received the polio virus vaccine. The meningococcal vaccine are now conjugate vaccines, so they're conjugated with protein, so it's a polysaccharide antigen conjugated with a protein. These are considered for travelers in areas where meningococcal disease is hyperendemic, so especially serogroups A and W in sub-Saharan Africa, or other areas where there are current meningococcal epidemics. Saudi Arabia, as I mentioned earlier, requires a certificate of immunization for pilgrims to Mecca or Medina during the Hajj. And it's also important to remember that there are many kinds of the vaccine, but recently, as of I think, especially in 2010, especially in the United States, meningococcal vaccine has been added to the immunization schedule, so most children have gotten the vaccine, and especially in college age children, it is a requirement for entry into college. They have to show proof that they were given the meningococcal vaccine. This particular slide I wanted to include to show you the clinical picture of meningococcemia. So this is what the vaccine wants to prevent. So in both pictures, you will see skin lesions of pulpura fulminans, so which are cutaneous manifestations of Neisseria meningitidis. And as I mentioned earlier, there are certain serogroups, so especially the four that are included in the most vaccines, so serogroup A, C, Y, and W135, that can cause infections such as severe infection manifestations such as purpura fulminans, and especially septic shock, and which can lead to death. In Africa, meningococcal disease is associated in areas that they call the meningococcal belt. So extends from all the way in Western Africa with Senegal and Gambia, all the way through Burkina Faso, northern Nigeria, Central African Republic, South Sudan, and then Ethiopia. So this is considered the meningococcal belt where there is a high risk of meningococcal disease. For the meningococcal vaccine, the widely used one is a quadrivalent, so which is a vaccine against Neisseria meningitidis serogroups A, C, Y, and W135. However, lately there's also a vaccine for meningococcemia serogroup, Neisseria meningitidis serogroup B. So for children 10 years or older, or even those adults with high risk conditions, these are patients who have persistent complement deficiencies, they have functional asplenia, or they have increased risk for meningococcemia, or let's say a laboratory worker who is exposed to isolates for Neisseria meningitidis. It is required for these patients to receive at least the 3-dose series of the Men B with actually and the conjugate vaccine. And there's also evidence that they receive this as they get the booster dose again after 5 years later, because of the question of waning immunity. For the cholera vaccine, the whole cell inactivated cholera vaccine is no longer produced, but there is now an oral cholera vaccine that has been approved for patients aged 18 to 64 years of age. So remember, cholera vaccine is given to patients who travel to areas where cholera is endemic. So cholera is an infection secondary to Vibrio cholera. Remember, Vibrio cholera is a gram-negative rod. The serogroups that we are really concerned about are those that carry the cholera toxin gene. So the ones that can really produce the acute watery diarrhea syndromes that can lead to severe dehydration and death are usually the toxin producing serogroups O1 or O139, and this are the serogroups that cause cholera, epidemic cholera. So as far as the vaccine is concerned, it is important to know that there is a single dose live attenuated monovalent oral vaccine. and this is used for travelers who are at least 18 to 64 years of age. Um, and this is given to travelers who go to an area or province or place where there is endemic or epidemic cholera, secondary to the toxigenic Vibrio cholera 01. It is important too that remember that there are also the three inactivated oral vaccines, but however, it depends on which country you go to. Some countries do not use those anymore. There's a concern also that actually some of these cholera vaccines can provide some protection against the heat labile enterotoxigenic E. coli infections. So um, it is also recommended for travel for certain areas that at least you get Vibrio cholera coverage and also for E. coli coverage. Um, in 2011, the WHO initiated a global oral cholera vaccine stockpile, so it could be used for rapid deployment during a cholera epidemic. A typhoid vaccine is recommended for travelers who may be exposed to contaminated food or water. There are two typhoid vaccines usually available, especially the one. So one is the oral vaccine containing live attenuated Salmonella typhi, the TY21A strain, which is approved for patients 6 years and older. And there's a parenteral VI capsular polysaccharide vaccine, which is approved for patients 2 years and older. So travelers should be reminded, though, that typhoid immunization is not 100% effective. So that typhoid fever can still occur. So both vaccines can protect only at least 50 to 80% of the recipients. And it's important that revaccination is required every 5 years for the oral vaccine and every 2 years for the inactivated vaccine, especially if there's continued or renewed exposure to salmonella. In this slide, I just want to remind the students that salmonella can be of two types. We discussed this for case 4 for our SGD. So there's typhoidal, which causes the typhoid fever and the paratyphoid fever, but there's also non-typhoidal salmonella, which causes gastroenteritis, so nausea, vomiting, and some fever, and food poisoning. For the typhoid vaccine, certain contraindications include for the parental vaccine, for the CPS vaccine, that it should not be given for those who have a history of hypersensitivity to any component of the vaccine. Now, for the oral TY21A vaccine, which is the live attenuated vaccine, it should not be administered to immunocompromised hosts, especially those with HIV, those who have a phagocytic cell defect, those with chronic granulomatous disease. Now, for these patients, the parenteral VICPS vaccine should be given. The oral 21A vaccine also should not be administered to those with gastrointestinal tract illness because at this point maybe the immune response to the vaccine may be diminished. It's also good to remember that in addition to the anti-malarial agent proguanil, it should not be also administered simultaneously with the oral vaccine, but rather it should be administered at least from 10 days or more after that fourth dose of the oral vaccine. So certain anti-malarial agents can interfere. So proguanil, atovaquone can interfere with the oral vaccine and especially can cause less immunogenic response. The next vaccine that we need to talk about is the rabies vaccine. It is important to remember when you travel, right, to avoid sort of close contact with certain animals such as dogs, cats, ferrets, bats, skunks, raccoons, even livestock, right? because in certain countries you are not sure of their immunization status for these animals. So remember, for rabies, there are two types. There's an active immunization and there's passive immunization. So rabies, remember, is a RNA virus that belongs to the family Rhabdoviridae, and it usually is associated with a bite. And the farther away the bite is from the brain, the longer it takes for the virus to spread. So therefore, the incubation period can be quite long. Symptoms in humans include fever, depression, agitation, and painful spasms. So that's why you have patients foaming after drinking, foaming at the mouth after drinking because of these spasms. So in this map here, you will see on this slide that rabies is quite endemic in parts of Asia, Africa, and South America. There are two types of the rabies vaccine that are usually available. So there's the human rabies vaccine, which is the human diploid cell vaccine, or the purified chicken embryo cell vaccine. And then there's a passive form of immunization, which is the rabies immune globulin. So remember, for passive immunization, you give half of the dose intramuscularly, and then the remainder of dose is given into the wound itself. It's infiltrated in the wound. Now, for active immunization, so it can be given post-exposure, so usually after a previously unvaccinated immunocompetent person sustains a bite, that patient will get a 1 ml dose of the vaccine injected intramuscularly in the deltoid area. So, and usually that's considered day 0. Then subsequently on days 3, 7, and 14 since the bite. So and most importantly is it's important to remember to clean the bite. And it's infiltrated with a rabies immune globulin, half of that dose during that visit to the ER. So what are the adverse reactions and precautions with these vaccines? So in adults, right, there's usually mild local reactions such as pain and erythema or swelling. However, immune complex-like reactions have been seen and observed in patients who receive booster doses. So the reaction characterized usually after 2 to 21 days after inoculation begins with a generalized urticaria, but can include also arthralgia, arthritis, vomiting, fever, and malaise. This reaction is usually non-life-threatening and can be seen in as many as 6% of adults receiving booster doses after their pre-exposure immunization regimen. So you have to caution your patients when they do get the rabies vaccine. If the reaction to the vaccine is mild, usually pre-treatment with some antihistamines can help. But then all suspected serious systemic, paralytic, or anaphylactic reactions to the rabies vaccine should be reported immediately to the physician. The next vaccine is yellow fever vaccine, but yellow fever is an infection secondary to flavivirus, which is secondary to a mosquito bite, mainly the Aedes aegypti. And if you look at this slide, it is found in mostly sub-Saharan Africa. So all the way in the west in Senegal, down south to Angola, and all the way in the eastern part of Africa involving Ethiopia and Kenya. This slide illustrates the early symptoms of yellow fever. So as you will see here, it's mainly the sudden onset of fever, chills. Usually you get a severe headache and back pain with myalgia and associated with nausea and vomiting. But the severe cases are the ones associated with high fever, hemorrhagic symptoms as gastrointestinal bleeding, and you get jaundice, which explains for the yellow discoloration of the skin and the sclera. The yellow fever vaccine is a live attenuated strain, and it is available only in state-approved immunization centers. And right now, it's believed that a single dose will provide long-term protection for most individuals. And unless it was contraindicated, yellow fever immunization is recommended for all patients 9 months or older who live in an area or traveling to an area where yellow fever is endemic. And as this map shows, there's a large part of this is in sub-Saharan Africa. It is important to remember now that booster doses of the yellow fever vaccine are no longer recommended for travelers. And it's felt that a single dose of the yellow fever vaccine provides long-lasting protection. However, in certain populations, additional doses may be needed, especially those women who were initially vaccinated when they were pregnant, those who have gone through a stem cell transplant, or those living with HIV, because they might not have had a sustained immune response to the vaccine. The yellow fever vaccine, as I mentioned, is a live virus vaccine produced in embryonic chicken eggs and is therefore contraindicated in those with a history of acute hypersensitivity to eggs or egg products, and especially also those who are immunocompromised. The adverse events for some of the first-time vaccine recipients can be divided into the neurotropic kind of symptoms or the viscerotropic, which is the multi-organ failure. And it's important to know that there are sort of absolute contraindications for the yellow fever vaccine. As I mentioned, so those who are immunocompromised, those less than 9 months of age should not receive the yellow fever vaccine. The next vaccine is for the Japanese encephalitis. It is the risk for Japanese encephalitis is really considered to be high in travel to Asia, but it also still varies in the sort of the destination, duration, season, and activities to these areas. So all travelers who go to countries that is endemic that has endemic Japanese encephalitis should be informed of the risks and should use personal protective measures to reduce the risk of mosquito bites. So in this slide, you will see areas or the map where Japanese encephalitis is noted to be endemic. So it's an infection secondary to a flavivirus. It is also important to remember, though, that the vaccine should be considered also for short-term travelers, especially if they plan to stay outside of an urban area or they have an itinerary of activities that will increase their risk of mosquito exposure in an endemic area. In this slide, you will see the life cycle of the Japanese encephalitis virus, where, as I mentioned earlier, it's a flavivirus that is usually seen in animals, but then because of the Culex mosquito, which is the common vector for this virus, the mosquito bites humans and transmits the virus to humans. There has been no known person-to-person transmission of this virus. So let us now talk about the vaccine. So the Japanese encephalitis vaccine is an inactivated vaccine. The primary vaccination series is usually 2 doses administered 28 days apart. So as you see in this table, it should be given to children 2 months and older. The dose differs from the 2 months to less than 3 years of age, then from 3 years to 18, then from 18 to 65 years of age, and then from those 65 years of age and older. So remember, it's usually a 2 dose vaccine. So, and it has to be given at least 28 days apart. So We have to advise our travelers that they have to be ready. In order for them to be ready to travel, they need to consult their physicians first so we can plan their vaccination schedule. We have talked about a few of the vaccine preventable diseases, but our next topic is COVID, uh, which actually, as unfortunately for now, the vaccine trials are still ongoing. So, what we really have to advise our travelers who go to COVID infected areas is that they really have to follow good personal hygiene, good hand washing, wearing a face mask, and follow social distancing. So for coronavirus, or for the virus, which is SARS-CoV-2, there are several vaccines in development, um, but they are all in different phases of the clinical trials. Remember, they're mostly from phase 1 to phase 4 before this vaccine can be available in public. So the major classifications of the upcoming coronavirus vaccines include the adenovirus vectored vaccine. Then you have the mRNA, which is a messenger RNA vaccine. Then there are the adjuvanted recombinant vaccines. And then there is the inactivated vaccine. So all these vaccines are in development. Many scientists hopefully will fast track the vaccines. But remember, the patients or who will receive these vaccines are usually going to be prioritized. So it will usually go to uh, the population that needs it most rather than travelers per se. So my advice is to look out for information. Remember also, look for reliable information on the vaccine. There is so much information on COVID out there, but be very discriminatory. So discriminate your information, read and verify your information regarding COVID. The next two viruses which can be travel related, though dengue is endemic in the Philippines, so we have dengue and chikungunya virus. So both of these are RNA viruses. So dengue is a RNA virus belonging to the family of flavivirus, while chikungunya is a single-stranded RNA virus belonging to the genus Alpha virus and Togaviridae family. Now, both of them have common vectors, so this is the Aedes aegypti mosquito, as pictured here on the slide, along with the Aedes albopictus. So for travelers, it is very important as physicians that we counsel them that they are to be very careful for regarding mosquito exposure. So should be a limit. There should be push to limit exposure to mosquitoes by telling them to use mosquito repellents, wearing clothing that covers the arms and legs, or in resource poor countries, using mosquitoes to cover you when you sleep at night. There are similar common manifestations for both infections from the chikungunya and dengue viruses. So both have acute febrile illnesses. Same thing as far as the myalgias, complaints of myalgias, pain in the eyes, and headache. But the fever of pattern of dengue is usually much higher than compared to chikungunya. And the concern is for dengue is that there are a subset of patients who proceed into hemorrhagic shock. Most patients with chikungunya infections recover. There is no antiviral treatment for chikungunya. Therefore, the primary treatment is really supportive, including bed rests, analgesics, or antipyretics. There are patients with chikungunya who complain of persistent joint pain, uh, but the use of nonsteroidal anti-inflammatory drugs usually can bring relief to these patients. Now, as far as dengue, there is a vaccine available, But unfortunately, due to the fiasco with the dengue vaccine trials here in the Philippines, currently this vaccine is not available. So, and, though in the future, once the vaccine hopefully will receive approval in the Philippines, this live recombinant live attenuated tetravalent dengue vaccine, which would hopefully be administered in a 3-dose schedule, would be a great way of preventing many Filipinos from getting dengue virus infections. So now one of the most feared travel diseases is malaria. And as you know, in the Philippines, malaria is still endemic in certain areas in Mindanao and mainly also in southern Palawan. So the concern we have with malaria, again, it is a mosquito-borne illness, and the problem for much of the Philippines is that it is found mainly in actually areas where there is a lot of woods and a forest. In the Philippines, we have still cases of falciparum and Plasmodium malariae. Um, and the rest of the actually Southeast Asia, though, we will see still Plasmodium vivax and ovale. So remember, for malaria, the vector is the Anopheles mosquito, and the concern we have is that several clinical manifestations that can be severe, including cerebral malaria, renal failure, respiratory failure, and vascular collapse and shock, can lead to death. So the concern for most of the world actually is whether there can be a malaria vaccine soon. So there are trials, but so far the trials have been mainly unsuccessful for the vaccine. So right now, what is advocated is prevention. So there are prophylactic drugs ranging from chloroquine, mefloquine, and a tovacone, progranil, which can be used depending on the resistant patterns of chloroquine in the certain area or country involved. So one the one drug, though, that is usually sensitive for most malaria would be mefloquine. However, this drug, mefloquine, associated with severe neurologic toxicity, including dementia, depression. So this actually is a warning used, or you should give when you give your patients prophylaxis for malaria. And remember, for prevention, these drugs have to be given at least 2 to 3 weeks prior to the travel, all right, of that patient. Then for at least weekly, when a patient is in the endemic area, they should take the malarial prophylaxis. And then, and when the patient comes back for another 3 to 4 weeks, the patient should receive the chemoprophylaxis for malaria. In the United States, the case fatality rate of falciparum malaria is 4%. And in these patients, only 1/3 of these patients die. And it was the diagnosis of malaria considered before death. So for most of these patients, remember, it's when they come back, they go back to their country of origin where they can have symptoms of malaria. Though the incubation period of malaria, remember, is 7 days. So we have discussed for the past about 45 minutes the different vaccines used to prevent travel-related illnesses and diseases. We have talked about your assessment for your travelers along with obtaining the appropriate travel history. So now let us talk about travel precautions. What do you have to watch out for? What do your patients, your travelers, have to watch out for, and what do they need to bring when they go on a short trip or a long-term trip. Now, for the next part of this lecture, we will discuss travel preparation. So it is important that you sit down with your patients who are about to travel and tell them you're concerned about their safety and that they enjoy their trip. But there are certain precautions and measures they have to prepare aside from getting the vaccines that they will need to do before they leave. So first, you need to discuss environmental precautions with a traveler. These include high or low altitude sickness. So for high altitude, you need to think about travel in the plane for long haul flights, right? The risk of thromboembolism. That is why most airlines now for long haul flights do some exercises because being sort of cooped up for at least a 12-hour flight and not moving can predispose certain individuals with pre-existing conditions to embolic phenomena. So aside from altitude, you can also have problems with temperature. So too hot or too cold, so hypothermia or hyperthermia can lead to certain diseases. So they have to be careful about their clothing when they are in different temperatures. It is important to address water exposure. As I mentioned earlier, for children, never leave children unsupervised when you travel because of the fear for drowning, but also for the exposure of dirty water. So like for flooding, right? You have to be careful about leptospirosis, or first, if you decide to wade into the rivers, then schistosomiasis is a concern. So those are a few of the environmental precautions. The next precautions that you warn your traveler about are the food and water precautions. So water, we talked about earlier about making sure children are supervised and that you have clean water. And in fact, for the most part, they should bring a water container, right, to fill with clean water, or really drink water from a water bottle. Two is that they should not have ingested ice, because some of the ice cubes can be contaminated with either E. coli or other bacteria. Then three, it's important that the food that they eat is clean, and the people that have prepared it have used sanitary and hygienic measures to provide food or cook the food. So therefore, one of the caveats, I think it's even in Harrison's, that they recommend, the travel medicine doctors recommend that you boil it, cook it, peel it, or not, you chuck it out. So you throw it away. So um, eating raw food is really highly discouraged when you travel. The next precaution you have to warn travelers about are the foodborne illnesses. So, what are these? So, first, let's talk about the E. coli O157H7. So, it's a bacteria that causes diarrhea, fever, vomiting that can lead into the hemolytic uremic syndrome. So, that is a concern mainly, especially for young children, children who are in daycare. So, and those children that can be exposed to food that is contaminated with E. coli. The next pathogen is norovirus, right? It is a virus that causes more GI symptoms, especially when you hear about people who have gone on a cruise ship, and where maybe hundreds to thousands of the crew and the passengers get sick with gastrointestinal illness. Now, third would be Clostridium botulinum. Remember, these are hardy bacteria that can resist drying and cleaning. These are spores that can live on surfaces for a while, and these lead into gastrointestinal illnesses. So these are bacteria and viruses that can be ubiquitous in places where people travel. Next, we warn our patients, our travelers, about bloodborne diseases. So bloodborne diseases when traveling can be um, transmitted, especially let's say the STD, so sexually transmitted diseases like syphilis, herpes, hepatitis, HIV, when travelers engage the services of commercial sex workers. Um, or they are involved also with drugs during their travels. So intravenous drug, especially intravenous drug use. Another concern for bloodborne diseases can be from getting tattoos or piercing during your travel or your vacation. Next, concern for bloodborne diseases can be during emergency surgery. Let's say you get a blood transfusion when you're traveling, or you get emergency dental surgery or any surgical procedure. You are at risk for bloodborne diseases. So on this slide, there are some travel medications that our patients can bring with them. So either just for prophylaxis or self-treatment. So let's say for malaria, they can bring chloroquine, but most of this of chloroquine, it should be for travel to areas where you know that chloroquine still works, that there is no resistance available. So nowadays, the prophylaxis that most patients when most patients use when they go to malaria infested areas include Malarone, which is atovaquone proguanil, doxycycline, all right, mefloquine, which is Lariam, which though I emphasized earlier can cause neurologic toxicity, has been blamed for suicidal tendencies because of the neurologic toxicity associated with mefloquine. And for Vivax Anavali, then the patient should bring Primaquine. For diarrhea, they can bring loperamide. However, nowadays, the antibiotics that most physicians recommend is, especially for children greater than 16 years of age, right? They can take ciprofloxacin. And then if there's a concern for Campylobacter, they can take azithromycin. Now, for high altitude sickness, the drug of choice to bring for prophylaxis is acetazolamide, which is Diamox, which you can use. It's a diuretic, which you can use for high altitude sickness. And for motion sickness, you can have the patient bring with them scopolamine, right? Or dimenhydrinate, which is Dramamine, so to help them with a feeling of vertigo and loss of balance. But of course, right, all these symptoms, if they do have symptoms, they have to make sure that they have a physician that they can call or they can reach out to when they're traveling. Through all the travel advice, we've gone through vaccines, gone through travel precautions. So now on the last part of this lecture, I will talk about some of the different countries and what precautions you have to take when you travel for these specific countries. So let us start with the Philippines. Most of the precautions for the Philippines have to do with mosquito-borne illnesses, and especially for dengue. So, and dengue virus infections are endemic in this country. So, most travelers really have to worry about dengue. Travel to Mindanao or travel to Palawan may warrant malarial prophylaxis, especially in travel to the Philippines. The next country is China. The CDC travel notice has warnings regarding cruising. Certain cruise ships have returned, and there are concerns for COVID transmission during taking these cruise. Earlier in the year, there were health warnings also regarding polio. There had been a few polio outbreaks in China, so the concern is that you should hopefully be adequately vaccinated against polio if you decide to travel to China. The next country with travel warnings includes Nigeria. Like all countries now, there is a warning for COVID. Make sure that you are aware of all the COVID guidelines. But Nigeria is unique because there have always been warnings for Lassa fever. So what do you need to know about Lassa fever? So remember, Lassa fever is caused by an RNA virus, mainly found in West Africa. It was first diagnosed in Lassa, Nigeria, hence the name Lassa fever. It is usually found around the areas too of Sierra Leone, Liberia, and Nigeria. And it is spread by rats or rat feces or water contaminated by rats. So one of the main ways to prevent these infections is to avoid any contact with rats. Make sure what you eat is cooked. There is also concern whether you can inhale some of these particles in the air with contaminated or infected rat urine or droppings. And rarely too that you can get sick with Lassa fever from direct contact with somebody with Lassa fever. So the key here for travelers is prevention. So make sure you warn them about these prevention measures that need to be undertaken. The next country with travel warnings that you will need to advise your patients is that travel to Saudi Arabia mandates that you take or receive the meningococcal vaccine, the quadrivalent meningococcal vaccine, along with receiving the influenza vaccine. So this next slide shows an illustration of the Hajj, which for most Muslims, most men, the Hajj is the fifth and final pillar of Islam. And if you look at the map below, from Mecca, they actually go to several other places before they circle the Kaaba 7 times at the end of their pilgrimage. So for those of you who've seen many pictures of this, there is very close contact to thousands of people. Therefore, the requirements of the meningococcal vaccine, influenza vaccine, and actually now in these days and times, precautions for COVID, very important during the Hajj. The next country for travel warnings and travel advice is Brazil. Brazil, as you know, is actually one of those countries reporting the highest rates of COVID. But now, aside from COVID, though, dengue is a concern. So there have to be precautions against mosquitoes that have to be taken in consideration. But also recently, it's been the Zika virus. So the Zika virus is a single-stranded RNA virus in the genus Flavivirus, and it's actually related to dengue, yellow fever, West Nile, and Japanese encephalitis viruses. So Zika virus is usually asymptomatic, but it is transmitted primarily to humans due to the Aedes aegypti mosquitoes and less commonly to the other Aedes species. The concern for most of this, for this virus, is that there can be mother to baby transmission. So you have a pregnant mother infected with Zika who, through the virus going through the placenta or infecting the placenta and then passing it on to the fetus. The concerns are for most of these babies that are affected with Zika is that they end up with microcephaly. So this virus, though, also can be transmitted sexually, so it's a concern too that there can be sexual transmission or propagation of this virus. Aside from sexual transmission and transplacental transmission, blood transfusion. So blood should be screened appropriately also for Zika virus, especially in places like Brazil. So the last country we are going to talk about is the United States of America. For most travel destinations, the United States of America was the most popular, easiest to get into, except maybe for countries like Iran and Iraq. But nowadays, because of COVID, there are certain citizens of this world or travelers of this world who cannot enter the United States. And now it includes China, Brazil, Iran, all the Schengen countries, and also even England. So because of the COVID pandemic, America has closed its doors to the citizens of the previously mentioned countries. In conclusion, we have come to the end of our lecture. Through this past hour, I have discussed travelers' health epidemiology. What are the important precautions and aspects of a person who travels? We have also discussed traveler's assessment, how fit your patient or your traveler is. The itinerary review, where your travel will take you, what precautions you'll need to take. We have talked about the risks to the traveler. And then last of all, we have talked about specific vaccines and immunizations, along with specific diseases and the specific countries and what the current requirements are for travel to those countries. So in conclusion, please read for more information Harrison's, right, chapter 119, along with just reading the uh, travel notices in the CDC guidelines, right, for travel guidelines, especially when you have patients or your family members who will travel. And last of all, make sure that your travelers, your patients will have a actually safe and healthy trip and actually bring back more memories of enjoying their trip and keep them safe and healthy during the trip. So thank you very much. And if you have any other questions, please let me know. There's a discussion board in Cello, or you can email me. So thank you for your attention.